Thank you to Christine Gilge and the board and supporters of Compassion Washington for inviting me to be a part of this conference, and to Grace Community Church for hosting this event. I apologize and regret that due to family reasons I cannot be with you in person. I also extend my gratitude to each of you gathered here today and hope that you will learn much, be encouraged to continue the work you have started, and to become more equipped to have a positive impact on the lives of many vulnerable youth and adults. This topic matters a great deal to me, and I wanted to share a few of my own experiences and lessons I have learned over the past 2 decades of working with survivors of human trafficking. You and I both know this topic is heavy, but I know you care because you are here, willing to listen to these difficult stories and want to engage in the fight. Please take care of yourselves as we go further. First, a little bit about me. I am a general pediatrician with specialty training in mental health, counseling, and the care of those with trauma stories. I am currently the director of the Foster Care Center of Excellence housed in Northwest Pediatric Center in Centralia, Washington. I'm speaking today from my perspective as a pediatrician who has cared for children and youth not only in foster care here in Washington State, but also survivors of human trafficking. I will not share identifying details about any of the youth, but I will be sharing some stories. I first became involved in human trafficking awareness and advocacy of victims of human trafficking close to 20 years ago, when one of my own clinic patients, who I call Mary, shared with me that she had been trafficked for close to a year while in local schools, with contact with a parent, and also visiting many local emergency departments. So many of us in healthcare missed her clues, and it is because of Mary and the many other patients and persons like her that I have met that I now try to provide holistic care for those with stories of trauma such as human trafficking. I dedicate my work in this field to Mary and others like her. Now, human trafficking is not just a criminal justice issue. It's not a personal or single individual issue. It's a community issue. It affects all of us, our children, our families, our community. It is a pediatric health issue because I have found that it intersects closely with those in foster care and also with those with histories of trauma and instability. Now today, I hope that we can define human trafficking in a youth-centered and clinically useful way. I hope to describe why foster care involvement can increase vulnerability. I'll briefly review the U.S. and Washington State human trafficking statistics and what these data tell us and what they don't tell us. I want to help us recognize common clinical presentations and the so-called red flags of human trafficking. But mostly I want to help us become informed and practice trauma-informed, safety-oriented responses and referrals. I want to focus on what those of us in healthcare and those who are child-serving professionals can do. Now, this session is about recognition, prevention, and response, not investigation or interrogation. It's a health and safety response training. But first, let's meet CJ. Now, CJ I met in my practice not long ago. Now, while CJ is not the real name, the details are very real. CJ is a self-identified female, 15 years of age, who has been in foster care since the age of 4. Now, we have lost track, but there have been at least 20 different placements for CJ. CJ is currently in a group home, and that's where I meet her. She carries a diagnosis of ADHD, or attention deficit hyperactivity disorder, PTSD, or post-traumatic stress disorder, conduct disorder, and polysubstance use. She admits to regular daily nicotine use, marijuana use, and occasional fentanyl, Adderall, and other street drugs. I come to learn that CJ is well experienced in living on the streets. She, in fact, has traveled from Bellingham to Vancouver, Washington, that's border to border of our state, several times. She knew how to find food, shelter, and even support her drug habit. This meant that CJ was able to secure funds while on the run. CJ had many contacts on the streets and was not alone in her travels. When I met CJ, she had just been released from a psychiatric unit for suicide attempts and for severe depression. I told CJ that she was one of the strongest people on the planet and one of the most amazing survivors to have survived all that she had. She had much to teach me and others if we would listen to her story. Now, we all know the definition, or perhaps this is a little bit of a review, the definition of human trafficking, which does involve the exploitation of another human being through force, fraud, or coercion for labor or sex. An important caveat here is that anyone under the age of 18 or a minor involved in commercial sex act is considered a trafficking victim without any means of force, fraud, or coercion. I want you to have special notice of the bottom here. I hope you can see it. For youth, trafficking usually involves grooming and meeting another human being to help meet their unmet needs. Youth like CJ may not label what we call trafficking as such. They may describe what they need to do as getting basic needs met, forming relationships, or survival strategies. CJ, in fact, mentioned several adults who had helped her along her many travels on the streets to help her get her basic needs met, some of whom she only met online. Now, if you don't know how many kids are in foster care, let me share with you a few statistics. The latest figures we have from 2023 show that there are over 300,000 children in foster care in the United States, with over 500,000 passing through the system, meaning they either enter, left, or age out of the system. That's a lot of vulnerable young people. Now, while it's important to tend to the medical and psychological needs of these youth, it is also vitally important to focus on their strengths and supports. As I mentioned to CJ, these are survivors, the strongest people in the world. It is not about focusing on who they are, their labels, their acts, but also focusing on what happened to them, and most importantly, what their strengths and supports are. Now, why is foster care involvement such a high-risk population for human trafficking? It's because of their unique vulnerabilities and histories. They do come into foster care with a significant trauma history. I've often said it takes crossing the threshold of trauma to enter into the foster care world. They may have abuse and neglect in their past. They may have complex trauma. There's also placement instability. There may be different placements, as I mentioned with CJ. They may have attachment problems and even attachment disorders and never quite learn how to form a healthy attachment or relationship with another human being. The runaway and missing episodes is the highest risk activity for these kids in foster care. This, which, as you've heard from CJ, is one of the ways that they try and make needs met or try and find freedom. But this is also one of their most vulnerable times to traffickers. And just like CJ, they want to have their basic needs met. Oftentimes, it's just the basics of food, housing, basic needs including clothing, medications. And yes, sometimes they turn to substances. Now there are also system gaps. While we may know of one system, such as a child welfare system, that takes care of many of these kids in foster care, we also know of the different systems that these kids in foster care have to intersect with. Educational systems, health care, social systems, even the legal systems. Now, I want to say that running away from in foster care is one of the strongest predictors of trafficking. Foster care all by itself does not cause trafficking. It's the instability, it's the running away, it's the lack of basic needs met that increases their vulnerability. Now, statistics tell us that 80% of trafficking victims will present to a healthcare facility. Trafficked youth are no exception, and in fact, they often present to healthcare long before law enforcement or child welfare gets involved. CJ and Mary, who I mentioned at the beginning, entered the medical establishment first before the legal system ever became involved. So what do we see with some of these kids in trafficking? We see some of the physical signs, sexual transmitted infections, pregnancies, injuries. We sometimes see sleep disturbances, or what I like to focus on a lot is the chronic pain syndromes. There are also mental health challenges, anxiety, depression, PTSD, substance use, addictions, and then suicidality and self-harm. And then there are the social and developmental challenges, school disruptions, disrupted or challenged or broken attachments in caregiving relationships. There may be legal and other services that have been involved. Now, primarily here, yes, we must address the physical, mental health, and social and developmental concerns, but our primary role is to assure safety, to demonstrate care, and to begin a connection, a trustworthy connection. Now, I have this slide here to remind us that the national hotline, the National Human Trafficking Hotline data reflects reports from people who reach out to them, not true prevalence. Youth, especially some of the most vulnerable, like those in foster care, will not reach out to systems, hotlines, or unknown groups for help. They are savvy, street smart, and they know how to survive. And one of those ways to survive is not reach out to one of the nameless or large systems. Therefore, these national and state statistics don't often represent how many minors are involved in trafficking. Healthcare settings, educational settings, and some social settings may be the critical points of identification of those in trafficking. However, I will share with you some state-specific information. These maps will ground trafficking risk locally. I call this where vulnerability hides. The first part of our geography are the urban corridors, such as along I-5 or 101. These corridors provide anonymity, opportunities for traffickers to find vulnerable youth online and to find and recruit groups of teens. There's transient housing along these places. Now, while there may be lots of people around and a high density of population, these trafficking victims, youth that are vulnerable, often disappear into the crowds. Then we have our central and agricultural regions, which have their own unique challenges of isolation, long distances between services, even healthcare facilities, and limited services for the youth that are most vulnerable. Now, as I showed you and shared with you before, CJ herself traveled from border to border. She said that she could make it from Bellingham to Vancouver, Washington in 3 days, and she did so with, quote, help from others. Now, from a pediatric foster care perspective, geography matters less than the instability, the vulnerability, and the risk factors that we talked about. I pay attention to the times when I hear of youth that have been on the streets for any period of time, and this matters not where in the state it happens. Now, how is it going to present? What do we look for? Well, there is no single indicator. I shared with you some of the constellation of physical signs, mental health descriptors, and challenges in education. So you could look for some of these red flags. Now, these red flags should be considered prompts for more questions, not proof. Yes, we'll look for repeated sexual transmitted infections and pregnancies and injuries, but as opposed to the typical role or description of a youth or a young person coming in with someone controlling their language, I don't often see that anymore. I see youth like CJ who come in, have survived time on the streets, have done what they needed to do just to survive, and come in saying, I need some help now. And they're not asking for help in leaving the trafficking situation. They're asking for help with dealing with some of these things, such as injuries or the chronic pain conditions I was telling you about. Now, Mary, who I mentioned earlier, she did have multiple visits to local emergency departments for those infections, injuries, and possible pregnancies. We did miss some of that early on. Thankfully, some of those same hospitals are now well educated and prepared to handle the next person that comes through with a story like this. So, what should we do? When you see any of these red flags, whether it's in your clinical setting, whether it's through your history or the context, avoid profiling. Just because a youth comes in with a little hesitation in giving their history, don't assume that something such as trafficking is there. Be aware and make sure that you have a safe, secure place for that youth should they decide to disclose whatever the history is, that they can find a trustworthy and secure and competent person. So I always say you can look at these red flags, but avoid profiling the youth and avoid pressuring the youth to disclose. And ultimately, don't panic if you do get a disclosure. There is a tool that many hospital settings use called the PAIR tool. If you reach out to me after this conference, I can get that resource to you. It's a great way to begin to create that safe place for youth and others, including adults, to feel safe with their stories. So, how should we ask and how do we prepare that place for a youth to share their story? It's all about being trauma informed and youth centered. Explain confidentiality and its limits. I use language such as a statement, I do ask these questions because it's my job to ensure you're safe. Some of these questions are private. Others I may have to share, especially if someone's hurting you. Now you can stop at any moment or pause. So be gentle, ensure confidentiality, and be specific. Don't, and see the slides here where it says avoid, don't be confrontational. Don't ask about why you don't leave the situation or don't you know better, but instead offer safety, offer trustworthiness. So it's more about not about helping to identify the youth according to a label, but it's about what happened to them and what supports are available to them. This again is where trauma-informed and youth-focused language is helpful. I often ask about their strengths, such as, tell me about your story. Tell me who your supports and your best friends or your friends are. And sometimes I am occasionally surprised, especially with someone like CJ who admits that there's an adult who's been helping her on the streets. But she starts to trust me. I ask about their gifts and their talents and their interests. I asked about their hopes for the next year, 5 years after high school, when they grow up, etc. So here's an example of a practical response path. Ensure privacy and safety. Address urgent health needs. Just like I said, when they come in and there's something such as an infection or an injury that needs to be addressed, address that first, but also ensure safety and privacy for that youth. Use trauma-informed language and documentation. Use the youth zone language. Try not to summarize or cast other judgments and accusations, but use the youth's own words. Try and connect them to a specialized referral or support person. If you get the disclosure that the youth may be engaged in trafficking or being pressured to exchange some of their services for basic needs, and you don't feel comfortable trying to get more information, enlist the help of an expert or someone who specializes in this. Social workers, advocates, outside referral services. Ensure the safety, including during and after the interview. One of the most harmful things we can do is unintentionally increase danger, such as confronting a trafficker or someone who you think is a trafficker or influencer in their lives, such as calling someone right in front of them or confronting someone out in the waiting room or near them. Find out what the reporting pathways are already in your clinical or other group setting. And if there are no reporting pathways, please remember that you are a mandated reporter in many situations, but inform the youth that you will need to share their story with safety personnel. Use the National Human Trafficking Hotline as a consultative resource. And if you don't already have a protocol for safety and disclosure in your clinic setting, set one up. Now about prevention. The strongest prevention is connection and stability. I want us to shift from those red flags to the protective factors to the supportive factors. The first step is connection and consistency, which are the most powerful protective factors, especially for the individual youth. Help them to know that you're trustworthy, that you will do what you say you will do. Don't promise something that you can't keep. For our systems that are already so overstretched and rather fragmented, try and advocate for rapid mental health access, substance use treatments, trusted adults and placements that are familiar with youth that are most vulnerable. Even small, consistent interventions do matter. Now, if you suspect trafficking, especially with youth, again, prioritize safety, but consider the multidisciplinary support. In foster care, I call this the foster care ecosystem. Address the urgent and immediate needs, but then know how to refer and where to refer. Always ensure safety and privacy, transparency and trustworthiness. But once you have a clinical protocol in place, things come so much easier. I've included a few resources here, but hopefully at the end of the conference you'll have a lot more resources. And I encourage you to write down one phone number that you will save and use and share in the future. Finally, key takeaways. Trafficking is not rare, it's not obvious, and it's not someone else's problem. We in healthcare do play a critical role in prevention and healing. So trafficking is a health issue. Our care can reduce harm even when disclosure is limited or non-existent. For youth in foster care, vulnerability is shaped by instability and unmet needs. Therefore, prevention is about connection and stability. The hotline data is useful for trends and context, but it is not indicative of prevalence, especially amongst our most vulnerable youth. In a clinical setting, prioritize privacy, safety, and a trauma-informed supportive network. Know your local protocols and save key numbers for future reference. Thank you for taking your time, for extending your interest and energies in this topic. And I thank you also for how much you care about vulnerable adults and youth. If you want to reach out to me, I have my work contact information on the screen. Please reach out at any time with any questions or comments. Thank you again for all the work you do, and thank you especially for the kids.
Hope, health, and healing. Compassion Washington.